So today we start with a very general introduction to the German healthcare system, and then going into detail. And we need these general information because later when we talk about appointment planning or some kind of operating room optimization, we should know the basic funding schemes and so on. This is why we start with rather boring content at the beginning, but we will need it later on. Okay, so let's start with basic overview of the German healthcare system. So we have the four basic principle of the German healthcare system is, and this is above everything, is the obligation to insure. So this is called Versicherungspflicht. So every citizen is obligated to be insured either publicly, gesetzliche Krankenversicherung, or via private health insurance. Okay, and this is valid only for a group of citizens, and so not everyone can go into the private health insurance. Okay. And this is based on contribution. So the healthcare is mainly funded through the contribution from the citizen. This is different than in, for instance, of course, it's a bit different. It's so the obligation to insure is seen by US as a communism concept, right? So maybe you heard about Obamacare because he also wanted to introduce this, that every citizen is somehow insured. But I think Trump changed it already, or is in the process of changing. But in US, it's a different story. There's the choice, the free choice, if you would like to be insured or not. In Germany, you have to be, and the funding is based on your income. So this is called solidarity principle, because you get the same care provision for everyone, regardless of your contribution. So if you're a high income person, you have to pay more for the insurance, but you get the same as someone who is, you as a student pay less for the insurance, but when you go to a hospital after a party, then they will treat you the same as someone coming and from a, I don't know, but still in the public insurance. Okay, so the contribution is based on the income here in Germany. And we have the principle of self-administration. So basically the German government decides on a general legal guidelines and frameworks, but the implementation of these frameworks, this is done by the different stakeholders of the healthcare system, by the associations of healthcare providers, of the hospitals, and so on and so on. Okay. So this is the basic structure. So do I have lost my one? So you have the German state that, of course, gives you the overall frame for legal enactment and supervision to the health insurers, but also to the health care providers such as hospitals, GPs, so the practitioners, and so on. And on the other hand, the German state, they refund the expenses of the health insurance. If they have more costs than expected, then the German state would refund that. And the healthcare provision, of course, they have to have these legal entitlements they can ask for, and everyone has basically to follow the laws. Okay, so this is the general statement here. And on the left hand, we have the payers, so the health insurers. On the right hand, the healthcare providers, let's say hospitals and physicians. And they have contracts with each other, but only the public health, so the statutory health insurers, have a contract with healthcare providers. And for each treatment, the payers give these payments back to the hospitals, the physicians, and so on. So you are basically here, you are the insurance, and you have the entitlement to benefits. So, for instance, you can ask for treatments. If you are ill, you go to a hospital, you get to a practitioner GP, then they will treat you. And you get benefits in kind principle, this kind of Sachleistenprinzip. So you are not getting some kind of monetary things, but you will be treated. So this is called benefits in kind principle. And on the other hand, you have to pay the healthcare insurance indirectly, especially so for the private patients, you have to pay them directly. For the statutory ones, you pay it with your loans. Okay, and then you are covered by the insurance company. Okay, so what kind of types of care do we have? So our healthcare system consists of ambulatory care, which is mainly provided by the physicians, but also by hospitals, for instance, emergency departments, or you need some kind of MRI scan, then you make an appointment in a hospital, but you don't stay there. You will go there for this diagnosis, and then you can go back. And the stationary care, this is provided by the hospitals if you need to stay overnight, for instance. Then this is the stationary care. Then you have the rehab if you have a serious accident or something like this. This is another healthcare provider. And of course, we have this long-term care. So one says that the better the medication is, the success of a medicine, the higher the share of ill people in a society, which sounds contradictory, but it's actually not, because earlier you died from some kind of disease like cancer, but nowadays the treatment and the medication is so good that you will survive, but you still need treatment because the underlying health issue is still there, so you are still ill, but with the medication you prolong that, so you have a higher share of ill people in the society, and of course you cost more then. Okay, the older population, the not that healthy one, they cost the society simply more. Okay, and the problem is, in Germany at least, that we have these social codes, but they are not really assigned to each other. So they are detached, and that's a problem, because every social code belongs to another insurance. So, for instance, SGB is a 5. The content is for the general healthcare rehabilitation for not working population. This is different than the 6th social code. This is for the pension insurance. And then we have the accident insurance. And this is why if you are at work and you had an accident, you will be asked if it was an accident at work, because someone else has to pay. I mean, you as a patient, you don't care. Someone is paying anyway because your treatment is covered. You are insured. But for the healthcare providers and for the insurers, this is a big issue, because they have to find out who's paying for what. And there's no incentive, because these codes are detached from each other. There's no incentive to work together. So a patient come again and again with different illnesses, and there's nothing that is close that we want to treat the patient in the right way, so that he's leaving this illness and leaving this circle of illness. Okay, so, and this is really a big issue, but it is like it is in Germany, and this is absolutely not really efficient. Okay, and the last one, this is this welfare. If you don't have money at all, then you will be still insured. Okay, this is the principle of the German social care system. Okay, so although this might be boring, we will need this information for later when we try to optimize things. Then we definitely have to know who's paying for what and what kind of funding is used. Okay, questions so far? Okay, then let's talk about cost coverage and benefits for the patients. So what about the health insurance? So we have two, yeah, please. You cannot hear me? Okay, I try. Wait. What about now? So it's oh no. Okay, 100%. I think I cannot make it louder. Okay, thanks for the hint. Okay, and now I hear my own voice. Oh. Okay, so we have basically two funding sources. One is the statutory, so the public one, and then the private health insurance. And you, as a patient, you have full coverage that covers all the necessary expenses. And what is necessary has to be defined, obviously. So what you think is necessary might be not, in a legal sense, necessary, or from the medical perspective is necessary. But in Germany, and this is the ground principle in Germany, that you have full coverage insurance. And you have a high number of benefits. So for instance, you can have this ambulant and stationary medical attention. So you can go to the hospital after a party, although you don't really belong there, right? So you can actually sleep or take aspirin and then that's over. But one can say that in Germany, 80% of the emergency patients in hospitals do not really belong there, because they have some kind of panic, or it's more convenient, they couldn't get an appointment with their GP, so they are going to the emergency departments, and they are overwhelmed and have higher costs, and the real emergency patients cannot be then treated properly because of this overcrowding. You get the medication. Sometimes you have to pay 5 years plus or 10 plus for particular medication, but actually it's also for free, and it's also covered. And you have this sick pay. So the good thing is, if you are sick and you're working, then you can stay at home and you are still getting paid, which is again this social principle of the German government and social principle. Okay, and these benefits are generated by hospitals, obviously, so you can always go to hospital, and especially to the emergency department, and then you can choose and you can choose which physician you can visit. This is a free choice for you. If you look at the percentage of statutory and private health insurance, you can see that almost 90%, it's from 2018, then Corona hit and kicked in, but I think nowadays it's pretty similar. I think it's maybe even 90%. It's a bit higher, the publicly insurance, but still didn't change that much. So we have the most of us insured publicly, and then we have the same share in private and of social security, and you can see that private and social security ones, so who cannot pay by their own, they are pretty similar, or which is what does it say about our society, right? If you get high income, you can insure yourself privately, but this share is the same as if you cannot pay at all. Okay, so the German society is somewhere in between. Okay, so we don't have a lot of privately insured, and we don't have a lot of social secured ones. And then we have these minor patients who are not insured at all, because sometimes if you are an entrepreneur, you can choose. So you can go out of the public insurance, but you don't have to go for a private one. So if you think you're healthy enough, then you can avoid that by not going and not insure yourself privately. Okay. So these are the others who are not insured at all. So if everything is fine, then you save a lot of money. But if you got ill and you have to pay by your own, then in a hospital, it's pretty expensive then. Okay, so who belongs to the private health insurance? So civil servants, like the professors at universities, for example, the civil servants and police officers, and so on. Then self-employed persons, entrepreneur people, and then someone who is not self-employed but has a high income. I think this limit is around 70,000 per year. So if you are above that, then you can still stay in the public insurance, but it's pretty expensive. So you can think of to change to the private insurance then. So and others not obliged to publicly insured ones. So as I mentioned, if you are an entrepreneur, you can choose not to be insured at all. And the insurance rate is based on the individual risk in the private sector, in contrast to the statutory insurance. So if you have, for instance, asthma or some kind of diabetes or something like this, in the public insurance, they all have to take you no matter what, and the income or the contribution you have to pay is independent of your risk factors, of your illnesses and so on. If you go to the private insurance, then you have to pay much more if you have this kind of long-term disease, diabetes, asthma, something like this. And if you have mental health issues, then they can reject you at all, the private ones, okay? And the private insurers, they offer often this complementary insurance also for the publicly and privately insured people. The dentists are the perfect example. Everything, I mean, only the very, very basic treatments, if you really have pain, then the insurance is covering that. Everything else, you have to pay extra. So the dentists are the perfect example for that. Or if you have, if you would like to have some kind of vitamin D test, then you also have to pay by your own. Okay, and on the other hand, in contrast to the private ones, the publicly insured people, they have to be insured. Then everybody that cannot be or is not privately insured has to be is obligated to be publicly insured. And of course, the legal basis for that is the Fifth Social Code. And in contrast to the private ones, you have this kind of fixed contribution, which is not dependent on your individual risk. So you always have to pay 14.6% of your earnings, okay? Till this kind of Bemessungsgrundlage, this limit of almost 4,700 per month, which is at the end, so roughly 7,000 per year. And the half of it you have to pay, and the other half your employee has to pay for you. So you're pretty expensive for the employee, because they have to pay this minimum of 7.3%, but it could be that if they have some kind of difficulties with their expenses, it could be that the insurance are coming to the company and saying, you have to pay more for your patient because we have so many expenses right now. Okay, so staff costs are a major point in hospitals also, that because, or in general companies, you are very expensive for companies. And I've seen that Tesla is now cutting again their staff members. And this, he said that's a very painful decision, by the way. Just wanted to mention that you are expensive. Okay. And then we have the long-term care, which is funded by the, again, the Social Code 11, and also the private long-term care insurance. So we have this public again and the private insurance, Pflegeversicherung. And the thing is that here we only have partial insurance. So not all expenses are covered for this long-term care. And the benefits, they depend on the care level. So if you have to care for an old family member who has a particular care level, they have 5 different levels. You get paid also for that, and you have benefits for this. So you can get a care allowance, you can use the ambulant nursing services, but also local resident care communities, Pflegewohngemeinschaft, or you have these nursing homes where they are treated and being taken care of all the time, okay, which is also pretty expensive for the society in general. Questions for the about the cost coverage and benefits? Okay, then let's talk about self-administration and funding of public health care. So we have this principle of self-administration. I mentioned at the beginning. The government saying about the legal framework and the general guidelines, but the implementation is done by the self-administration. So based on this principle, those affected, so all the stakeholders, those affected should work together with direct responsibility on the social challenges of the public health insurance. And those affected are, again, hospitals, rehabs, and all the other healthcare providers we mentioned before. And the self-administration organizations, they are equally occupied by representatives of the insurance on the one hand and the service providers, hospitals, and so on. And they have to agree on this implementation. Basically, they have this general framework and they pass the legal standards. So they do the detailed stuff to regulate the individual actors, for instance, the range of services they are providing, but also the guidelines, general agreements, but also fee regulations. Okay. And in Germany, we love these kind of organizations. We have several ones. We have the associations of statutory health insurance, so the gesetzliche Krankenversicherung, the group of just the insurance companies. Then we have the Association of the Physicians, Kassenärztliche Bundesvereinigung, then the Central Association of Statutory Health Insurance Dentists, because we all know dentists are not real physicians, so they have their own group, okay, so they are separate ones. And then we have the German hospital associations, and they are controlled basically by the Federal Ministry of Health and Federal State Ministries of Health. You know, Germany has these kind of federal states, so each federal state has its own Ministry of Health. That is again checking these organizations, how they implemented these guidelines. Okay, the health insurance. So these are the institutions of the public healthcare system, basically, and we have the freedom to choose which one we would like to be insured by. AOK, BARMA, DRK, something like this. But we have the obligation, or let's say the healthcare insurance, they have the obligation to take you, okay? And no matter about your risk, no matter what kind of health issues you have, if a person is contacting you, they are obligated to take you. If you are a private patient and you see that your company is going down and you would like to change back to the public insurance, that's not as easy. Okay, so it's very complicated. I would say even almost impossible to change from the private insurance to the public insurance back. Okay, but if you are not insured, then they have to take you. And then we have these, again, this principle of benefits in kind, so all necessary. This is the key point here. All the necessary expenses are paid by the health fund. You don't see the bills actually. So if you are publicly insured, then you simply show your card and this is covered by your insurance. You don't see how much your treatment costs, how much it was for the blood results or something like this. This is definitely different to the private insurance. You have to pay for the treatment, so you get a letter and then you have to pay for that, and then you can get it back from your private insurance company. Okay, and Professor Nickel said that he is privately insured, and he said sometimes he was calling and said, that was not me who was treated, because there was a list of different things, and 100 euros, 200 euros blood result, and he said that it was me whom you've treated, because it's really expensive, and they charge you for everything. Basically, if you talk to him for 10 minutes, you instantly will be charged for 100 euros. Okay. And this is a special thing in Germany. They are not allowed to reserve capital, so they are not allowed to save money. All the capital surplus of the health insurance goes back to the insurance, back to basically to you. I've never experienced that actually, but in theory they are not allowed to save that. I mean, this is reasonable, because otherwise they have this incentive to make more profit instead of simply giving the best for the patient, right? Okay, but as I said, I've never experienced that I got something back because I was so, or the society was healthy this quarter in the year. So how is the funding working? So you as a patient, you can choose which healthcare insurers you would like to be insured by, so AOK, DRK, BARMER, whatever, but you are not paying them directly. You pay indirectly with your loan and your earnings, depending, so these 7.3% you have to give to the Central Health Fund, and they give the budget back to the insurance companies, but based on the risk adjustment scheme. This is to equalize the financial consequences of unequal distribution, so based on risk adjustments. So for instance, our car has a high percentage of diabetes patients or asthma patients or older patients, for instance. So they are more costly than the other patients, the younger ones, okay? And based on these risk factors, they pay more for our car than for BARMER, whatever. It's just an example. I don't know who's paid more, okay? And who has this more adjustment scheme. So the health insurance receive adjustments, payoffs, if they insure a lot of risk patients, so sick patients, right? So and this should elevate the pressure to recruit only young and healthy patients. So this is the main idea of it. Okay, so then the statutory health insurance physicians, so only physicians that are members of the Statutory Health Insurance Association, again, this fancy word, only the registered physicians can treat publicly insured patients and of course get paid for it. So maybe sometimes you experience that you called a clinic and a GP and they told you, yeah, we are only accepting private insurance patients. This is because they are not registered and they won't get paid for you if you are a publicly insured patient. And the associations of these statutory health insurance physicians, these Kassenärztliche Vereinigung, they negotiate the total remuneration for health services, okay, provided by their physicians. So this is also political incentive to negotiate more for their own physicians and for particular health services. And then these Kassenärztliche Vereinigung, they split the remuneration between their physicians based on this federal level you are in. And also, so we have several federal states, and therefore we have 17 regional Kassenärztliche Vereinigung, these associations by the Central Association of Statutory Health Insurance Physicians. My goodness. Okay, and then again, in theory at least, patients have the freedom to choose which physician to visit. However, in practice, it's often that they're overcrowded and you cannot get there. So I tried for my kids to get an appointment, but they said we only accept patients in nearby our clinic. So I couldn't get an appointment. So although I have theoretically the choice. The physician, if they are overcrowded, they can reject you as a patient. Okay, so let's go to hospitals. Only hospital listed in the so-called federal state hospital plan, Landeskrankenhausplan, only there are allowed to treat publicly insured patients and again get paid for it. So the federal state hospital plan, they decide where a hospital can be built physically, the building. And then again you have to register, and then you can be paid for the treatments you are offering. And hospitals, they again close contracts with health insurers about the kind and amount of services, and also about budgets. So if you are a specialist and you have a heart center, cardiologic, or you can implant organs, then you get more budget, but it's difficult to get these contracts. Okay, so this is a very scrutinized legal process you have to go through. Okay, and they're organized in central and state federal associations, of course, and then also in the German Hospital Association on the federal level, again, depending on the federal state you are stated and located. So, and patients have, and this is different to other countries, patients have again the freedom of choice to which hospital to go. This is different to other countries like, for instance, Portugal. You are told which hospital to visit. Here in Germany, again, at least in theory, you can choose. So if you would like to go to Heidelberg, you are free to do so. Okay, then we have this joint federal committee, which consists of the Central Association of Statutory Health Insurance Physicians, again, this Kassenärztliche Vereinigung, then the Central Association of the Insurance Companies, and the Hospital Association, and then we have a joint federal committee with the dentists, so this is the dentist here, and then 3 neutral members, and their tasks are to define guidelines. So the general framework is done by the government, but the guidelines, they can define these ones for the service catalog, and they decide the measures to secure quality in also ambulant and stationary care. So if you can go home at the same day, or you have to stay overnight. Okay, and we have this quality, the Institute for Quality and Economic Efficiency in Healthcare, which is basically a monopole, and this is only consisting of physicians. So this won't happen in the industry, for instance, because they simply look at the quality and economic efficiency from a doctor perspective. But there are no engineers there, no mathematicians, no one who's checking other processes if they are efficient, if they have higher quality. Okay, so this is one perspective they are looking at, but it's unfortunately not a comprehensive one. Okay, so and this joint federal committee defines at the end the services, so the medical treatments that we will be reimbursed by the public health insurance. So which is also again important because they get money for that. Okay, questions? Okay, then let's go for the remuneration for registered physicians. So the compensation carried again by this Kassenärztliche Versorgung or Kassenärztliche Vereinigung, they are based on this distribution scale, the Honorarverteilungsmaßstab, and in general it depends heavily on the federal state you are in, but in general you get a fixed amount of money for each quarter of the year, and the basis is the so-called uniform rating scale, which defines points for services. So you get a particular number of points for blood tests, and another one for physical treatment, and then for diagnose, MRI scans, or whatever. So for each service you get points, and the value of the point is not fixed, but they can vary quarter to quarter depending on the if we have a winter season, if we have a high number of flus, for instance, and you have asthma patients or something like this, you have to treat more than in summer quarter. And if the physician works more than allowed, so let's say you get budget for treating, let's say, 100 flu patients, you can prescribe medication and so on. And after that, after this point, you get less and less for treating more patients. Okay, and this sometimes you hear that doctors say, from this point on, I treat the patients for free. Okay, because he has much more patients than expected, and than the budget he has. So if the physician works more than they allowed by this budget, then he or she or they gets then the share of the leftover money from the KfW for this particular region. Okay, so but it depends. But it depends on the budget, and this is the very difficult part also for the physicians. They often don't really understand how they got this budget. So if you are here in the first quarter, so you have the first year and you have 4 quarters, and then the physician would like to know what kind of budget they will have next year in the first quarter, then they, so by the way, if I say he, I mean in general the human being, okay? But I try to be as gender specific as possible. So they have to multiply the number of cases, multiplied by the case value, and times the possible correcting factors to understand what will be the allowed amount of budget next quarter. So the case is simply the same quarter, the same patient, the same health insurance. So if you go once a quarter to the doctor, to the GP, he loves you. If you go twice in the same quarter, they accept you. If you go more than 3, they start to hate you because they don't get money for you, because you are treated as the same case. Okay, and they will be paid for you once in this quarter. So they see you as one case, and the case value is simply the total amount of budget or money for this group of physicians, GPs, for instance, or therapists, divided by the total number of cases treated by all of these physicians in this particular region. Okay, and the case value further and further diminished then if the physician has to treat more and more patients. Okay, so especially if you group by 150%, 170, or 200. We will see that one in the exercise, how to compute that. And the correcting factors might be age, might be the underlying disease, or something like that. Okay, so it's, as I said, most physicians, they don't understand how they get this budget. They simply receive the budget, accept that, because it's pretty complicated. What is the case value, or especially what is the correcting factors? Okay, and how does the remuneration works for the private patients? So we said that you are paying that directly to the GPs, and then you get that back. And the billing that they are issuing, they're according to the scale of fees for physicians. They send it to you, and you have to pay it and then get it back, as said. And in general, they've applied the maximum rate, which is 2.3 times of the basic fee. Don't ask me why. We don't know why it's 2.3. Okay, and no one ever experienced that they they apply less than this maximum rating scheme. Okay. In contrast, the general or the public insurance, they fund you 1.7 times the basic fee. Again, from where the figures are coming is absolutely unknown. But in complicated cases, so again, the dentists are the perfect example. They find always a way to treat you and apply more, and even apply 3.5 times the basic fee, which is the absolutely limit of what can be done. So they're really good in defining what cases are very, very complicated, and they have to bill you more than that. Okay, as I said, especially the dentists are pretty good in this. Okay, and in addition, they can also offer you individual health services called Eagle for everybody, so the patient have to pay by themselves. So even if you are publicly insured, you can buy extra treatments. Okay, this vitamin D test, for instance, you have to pay for your own. Okay, questions so far? Okay, then the last section, the review and also opportunities. So let's have a critical look at this. So the German healthcare system, they generate really high costs. So from 2017 to 2020, we have this high increase in general national gross product. So we pay over 5,000 per capita, which is really high number. I think especially the northern countries are better in this. So we have really these high costs, and their costs also increase faster than this gross national product due to aging society. Of course, we are getting older and older. Then we have an increased demand due to higher expectation of the consumer. So as a patient, we are coming and we have also higher expectations. And of course, we have these, if you need better medication, then we have this increased supply induced by the demand. So if we need more asthma sprays, then we have to, we need the according supply for that. And we've observed this trend to defensive medicine, which means that often doctors are providing you with treatment that is not really necessary, simply to avoid some kind of lawsuits. Okay, so if you are coming to a doctor and you are complaining about back pain, the general procedure is giving painkillers or giving some kind of physiotherapy. But what is often done nowadays is that they prescribe an MRI scan, which is extremely expensive, just to avoid that something was missed and that he got suited. Okay, so this is why this is a trend which is pretty expensive at the end for the entire society. And the cost cutting reform, it was and it is still moderately successful. So, and of course we have the increased costs are shifted to the consumer. So we as end consumer, as an end patient, we have to pay more and more, and we have these that we're not looking at the patient health status at all anymore, but we are rather concerned about our profits, about decreasing costs, and so on. So this is a sarcastic, funny part of it. And looking at the supply, so we have a high provider density. We have a lot of hospitals, but we have decreasing tendency. Maybe you've heard about this dying of hospitals, especially in rural areas. We have almost 200 registered physicians, and we have a high number of medical treatments. So, for instance, we had 255 hospital discharges per year per 1,000 people, or this is really crazy, 18 physician visits per year and person. Can you imagine that you as patient are visiting a physician 18 times a year? So basically more than every month, which is really a lot, let's say. And to achieve a higher profit, what is done is that hospitals and physicians are trying to offer more services, which you have to pay by your own, this kind of vitamin D or some kind of unnecessary treatments, vitamin treatments, maybe acupuncture, something like this. And they try to increase the number of patients treated. So for instance, again, the northern countries are better than that. They take some time for their patient, 22 minutes on average, whereas in Germany it's 8 minutes, and sometimes even less if the flu season is ongoing. And they get, because of this, less and less remuneration. Okay. I wrote here down some sources if you are interested in some details. It's in German, but maybe you are interested in that. And the other critical things we have to consider is the quality. Okay, so what we know is that care, as the entire Germany is, we have several federal states, and the same holds a little bit for the care. It's highly fragmented, so we have too many service providers with too many services offered, but the expertise is not there. So even if they offer you acupuncture, that doesn't necessarily mean they know what they are doing, because they don't really have experience with that. They maybe have a certificate, they have attended some kind of course, workshop, whatever, a weekend workshop, and then they have this certificate, but that doesn't necessarily mean that they're really experienced with that. And we have a high variability in the quality of services, even if we know the type of disease. So if you come with flu, one doctor is giving you antibiotica, another one just says you have to drink more. So the quality of care and the services are also highly different, even if, as I said, even if the disease is well known. Let alone if the disease is unknown or they are not familiar with that, then they simply really don't know what to do with you. And the main problem is that we don't really know how to measure the quality of the treatment, the outcome. Okay, so in a quantitative way. Of course, in hospitals we have this kind of if you got an infection after surgery, this is a quality measure, but it's not really useful also for GPs for normal treatment and other treatments. What about cyber attacks? How to treat the patient during if you cannot access any kind of blood results anymore, and you prescribe a wrong medication. Okay, how to measure that one? So we don't have that, and the sad thing is that we're not really focusing on making the patient healthy again. It's good if the patient is ill, then they are coming back, so we can treat them again and again and again. So they're not really interested in making the society more healthier. Okay, maybe some opportunities and recommendations. Maybe we should focus more on maximizing the outcomes and the patient value instead of trying to cut costs. So health should be less expensive, and is less expensive than sickness. And this we have to understand. The physicians have to understand. All the healthcare providers have to understand this principle. And the integration of treatments, build treatment chains, collecting different stakeholders, the ambulant care, acute care, and so on, so to jointly maximize patient value and its health status. And also building some integrated practice units that entirely focus on the treatment of one particular disease and its implication. Okay, so simply to gain expertise, experience, and to know how to treat them efficiently for this particular disease. and of course limit the spectra of services. So rather having specialists than GPs that offer everything. And at the end of the day, measuring patient value for every, also for common diseases and provider, so that we have better feedback for providers and also better decision support for patients, so that they know to whom to go to be treated. Questions for this lecture? Okay, then I thank you very much for your attention. We will see each other online on next Monday if you have questions. Otherwise, just enjoy. And then we see each other next Tuesday. Okay? If you have any questions, then use the forum. Okay? I will answer that. Thank you for your attention. Thank you. Bye.